Good afternoon, everyone. I welcome you all to ET Health World webinar. To present this webinar, I welcome Dr. Abhay Agrawal to share valuable insights on the topic, Is Robotics the Future for Bariatric Surgery? There will be a presentation on the topic followed by a question and answer session wherein you may submit text questions to today's presenter by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the question and answer session at the end of the presentation. Now I request Dr. Abhay Agrawal to start the presentation. Over to you, sir.
Good afternoon, everybody. It is a pleasure and honor for me to share my experience with you. I'm a bariatric robotic surgeon based out of Mumbai in practice for last 21 years, and my prime interest is morbid obesity and uncontrolled diabetes in patients who are finding it difficult to lose and maintain weight on their own and to get rid of their diabetes and other metabolic issues. So the topic today is robotic surgery, the future of bariatric surgery. Robotic, in short, is a tool, a very powerful tool which we surgeons now use in difficult cases where laparoscopy alone is not enough. All bariatric patients, give or take, are difficult patients to manage surgically because of the size, because of their morbid conditions, and their compromised organs in terms of anesthesia, in terms of managing post-op care. So robotics does help the surgeon a lot, and it is a tool which is going to be the future of surgery to begin with. This is how a typical robotic console looks like. So what you see at the on the table along with the patient is the robotic console, which has 4 or 5 different arms labeled as 1, 2, 3, 4, and 5. And these arms are basically holding a different instrument. Each arm is allotted an instrument. And all these instruments are together controlled by the surgeon who's sitting scenes on the console, who sits on a 3D console. We get a 3D vision. The surgeon is relaxed in his chair and he's controlling all the arms with the 2 hands and the 2 feet. And he can move the camera, he can give commands for each arm individually. And the advantage of robotics is that in difficult cases or in cases where we are experiencing long hours of surgery, the robotic arms don't show signs of fatigue, whereas a surgeon can fatigue out. There is a lot of torque in these obese individuals. Torque as in the instruments are kind of just adhered and in a single direction. We cannot move them. There is no fulcrum to move. In case of robotics, this disadvantage is overcome. Plus, the surgeon can sit comfortably and operate at the same precision, the same intensity, and the same depth, even after 2 hours of rigorous surgery. So this is how a typical robo looks like. The most common is the Da Vinci system, which has different versions. Now they have come out with the HD version. So coming back to obesity, the WHO statistics world over says that there are about 1.9 million adults above the age of 18 who are obese. Worldwide prevalence of obesity has doubled in the last 15 or 20 years. We are finding more and more younger individuals and children who are obese. Estimated 41 million children are under the age of 21 who are obese. And nearly half of these children are from Asia, which is surprising. So Asia is the diabetic and the obesity capital of the world, so to say. Asians genetically have a higher body fat percentage and so are prone to obesity and diabetes. So does every obese patient need surgery, or can we try them out with diet and exercise? So of course, the first line of management for obesity is exercise, lifestyle changes, drugs if necessary. And if these are not successful, then surgery is the answer. Sometimes, in spite of the best efforts, these patients are not able to lose weight, and surgery is the only answer. As I was telling you, that Asians are known to have higher body fat percentage compared to the Caucasians, and so we are prone for obesity. Obesity is classified into different types of obesity, and depending on the degree of severity, we classify it as overweight, obese, or morbidly obese, and super obese. Normal BMI is 18 to 23, 23 to 27 is overweight, 27 to 32 is obese. You see, I've drawn a line after 32. So after 32, most of these patients fall into the morbid obese category, wherein regular lifestyle, non-surgical, conventional methods of weight loss are seldom successful. Most of these patients do end up on the surgical table. What causes obesity? Why do we have obesity to begin with? It is simple calculation of the amount of calories you take in versus the amount of calories you burn out. Most of us are into processed food nowadays. Children are eating a lot of junk and a lot of consuming very high calorie food and are not able to burn for different reasons. It could be a slow metabolism, it could be endocrine malfunction, or it could be just lack of physical activity. Surgery criteria, as I said, individuals above 37 BMI are eligible for bariatrics, or 32 BMI associated with comorbidities like blood pressure, diabetes, arthritis, sleep apnea. More or less, anybody who's 30 kgs above their ideal body weight do fall into the surgical category. What does obesity do? Is it only a state of physical obesity, or does it have medical effects? Of course, it has a lot of medical effects. Morbid obesity leads to very high chances of diabetes, blood pressure, high cholesterol, hyperlipidemia, cardiac diseases. Most of these patients suffer from respiratory diseases like sleep apnea, osteoarthritis, they have pain in their knees. Most of them have depression and other joint pains. What are the options? Conventional methods, as I was trying to tell you, diet, exercise, behavior modification, anti obesity drugs. In the long term, they may lose weight in the short term, but in the long term, there is almost 95% failure in the morbid obese category. Surgical therapy, on the other hand, has almost 80 to 90% success rate even in the long term. Most of these patients are able to maintain whatever they lose for a long, long time. Why undergo surgery? There are definitive indications for surgery and health benefits. It improves health condition, the weight loss is sustained, there is reduction of life-threatening risk factors, there is improvement of your daily activity, your movement, your well-being, there is improvement in self-esteem and psychological aspect. Most of these people suffer from a low self-esteem, and after surgery they are in a different planet altogether. They're full of confidence and brimming with euphoria. As I said, most of these patients who undergo surgery are followed up for a long period, and what we have observed in our 20 years of practice, most of these patients maintain up to 80 to 90% of their excess weight that they have lost very comfortably. Most of my patients ask me, Doc, why do we need a surgery? Why can't we just eat less? And anyways, you're going to staple the stomach, you're going to make the size of the stomach a little small. Why can't I just do it on my own? Well, surgery is exactly opposite of dieting. In diet, your appetite is still high, patient is still hungry, there is no satiety, the mind is constantly telling the stomach not to eat. Whereas after surgery, I'll explain how things work, but the appetite and the hunger actually goes down. With a smaller amount of food, the patient feels more satisfied and there is higher level of satiety. On the other hand, the metabolic rate changes. So these patients, whatever little food they eat, they're able to burn them out more effectively. So they actually do not accumulate unutilized calories. So metabolic rate changes after surgery, and the feeling of fullness, feeling of satiety is much higher. The main hormone to be blamed for obesity is ghrelin. This is one of the chemicals which is situated in the top part of the stomach. Stomach has three parts. So the fundus of the stomach, where the ghrelin sits. What does ghrelin do? Ghrelin creates hunger and cravings for in human beings. So whenever we get these hunger pants, it is because of the ghrelin levels going down. In surgery, and the sleeve gastrectomy or the gastric bypass, this portion, the top portion of the fundus of the stomach, is actually stapled and removed away. So this gives the patient less ghrelin and they don't feel hungry or cravings for wrong food. Along with that, metabolic syndrome of the body organ deterioration is arrested. In short, all this diabetes and blood pressure, they are actually damaging the organs. Once we control the diabetes, the organ damage is arrested. Patients don't develop complications because of diabetes, hypertension, cholesterol. Body loses extra fat and is in a state of well-being. Most of these people have a negative or a little restriction towards surgery. They always feel bariatric surgery should be the last resort. There is always a fear of surgery among our population. Bariatric surgery is often viewed as cosmetic procedure. Obese patients usually have their friends and family who are trying to tell them that they should lose weight more naturally. They should not adopt to surgery. So there are different opinions in the market, and people feel that bariatric surgery is something which should not be the first step. I would change the opinion in my the next few slides. Most of the people feel are scared of surgery because there are certain news which come out that some certain people must have died or something. But of late, in the last 20 years, the technology has changed so much. There is so much of improvement in anesthesia machines. The surgeons and the doctors experience that now this surgery is comparable to any other regular surgery like a gallbladder or hernia. Bariatric surgery is as safe as a gallbladder or hernia surgery. The mortality rate is only 0.28%, that too in cases who are extremely unwell. Otherwise, most of these surgeries go very well and patients do very well after surgery. There are different types of procedures that we can do. The most common world over is the sleeve gastrectomy or the stapling, as the common people call it. In the stapling, what we do is we reduce the size of the stomach by stapling and making it into a J-shaped organ. The fundus is obviously removed so that we get rid of the ghrelin. Most of these patients lose about 75 to 80% of their excess weight. The other most popular and the oldest surgery is the gastric bypass, the Roux-en-Y gastric bypass. Well, it's a surgery where we create a small stomach pouch and bring up a loop of intestine and join it to the stomach. So patient eats a small amount of food and a part of the intestine is bypassed by not absorbing the unnecessary calories from the food that they eat. In this surgery as well, the patient lose 70 to 80% of their excess weight and can maintain it very easily. I'm sorry, I skipped. So coming back to robotics, all these surgeries are now comfortably done with the help of a robo. This is how you sit on the console of the robo. These are the two control joysticks that we see. Here we are having a 3D vision in the console, and there are foot switches which control the camera. And so there are 1, 2, 3, 4 different arms logged on, latched on to the patient. The camera has a separate control and the other 3 arms have a separate control. There is an assistant surgeon who's standby and is helping the surgeon change the instruments if necessary or introducing some extra instruments if needed. And this is how the complete surgery is performed. Latching the robo on to the patient takes about 10-15 minutes. So that's a little added time that the surgeon spends in a robotic surgery. Of course, because of the cost involved, robotic surgery is a bit more expensive than regular surgery. But then at the same time, this surgery has more precision. The surgeon's ability to perform after 3 hours or 4 hours of extended surgery is much, much better. And this is how, so the most common system we use is Da Vinci. There are others in the market which are soon going to be launched, and we will have a whole array of robos in the near future. In US is the mecca for obesity, as they call it. The maximum number of bariatric procedures are done in the US. If you compare the data in 2014, there were about 10,500 cases done in India. In 2017, the numbers have doubled. We have clocked more than 20,000 cases. This is how fast bariatric surgery is developing in this part of the world. US has about 250,000 cases being operated every year. Coming to some data, this is a randomized trial from 4 teaching hospitals wherein they compared lifestyle management versus gastric bypass surgery and the success outpoint. So they compared 3 parameters of blood pressure levels, the sugar levels, as in the average of 3 months HbA1c, and the cholesterol levels. After 12 months, what they recorded that there was 49% success in the gastric bypass group compared to only 19% success in the lifestyle management groups. There is clear indication that bariatric surgery is the most powerful medium for bariatric patients and morbidly obese patients in controlling diabetes, blood pressure, cholesterol. There's another trial, the Stampede trial, which was conducted by Phil Shower. For 3 years and 5 years, he has published both his data, where else he compared bariatric surgery against intensive medical therapy. And what he realized that HbA level 1c of 6 or less was achieved in only 5% of medically managed patients. 6 is the ideal HbA1c level of or non-diabetic level, whereas in the gastric bypass and the sleeve gastrectomy patients, they clocked 37 and 25% success rate in terms of achieving complete remission of diabetes. So this is how successful bariatric surgery is. The prime reason for change in diabetes is the insulin resistance. Most of these patients, because of the extra layer of fat, they develop an resistance towards insulin. Whatever insulin is being produced is not acting effectively enough because of the fat. It produces a barrier. So once the patient loses weight and the insulin resistance goes down, the same amount of insulin is much more effective. So cure of diabetes and obesity is not only dependent on weight, it is dependent on other factors also. This is how effective different types of procedures are in controlling diabetes, the gastric band versus the sleeve versus the bypass and the BPD. As we see, the bypass or the ileal transposition stands a better chance in controlling diabetes compared to the gastric band. Gastric band is now getting obsolete and we don't do the gastric band at all. Sleeve is effective in short-term diabetics, but long-term and uncontrolled diabetics, the ileal transposition is more effective and it is a pure metabolic procedure. The mechanism of diabetes in obese is predominantly because of the insulin resistance, as I told you. What about the non-obese individuals? So somebody is not so obese but has uncontrolled diabetes. In the non-morbidly obese patients, the main problem is gluconeocentric disease. We need a strong GLP-1 effect in these patients to control diabetes. They need not necessarily lose weight, but we can still get them in control by increasing the GLP-1. I'll exactly tell you how we do it. The other study, we found out that if you are a diabetic for a shorter time of frame, your effective control is better. So there was a study which studied diabetics for less than 5 years and diabetics for more than 5 years. The remission rate was almost 90% in short-term diabetics compared to 57% in the long-term diabetics. Less BMI patients, less than 30 BMI patients were more difficult to control diabetes compared to the or morbidly obese patients. Above 30 BMI were more easily controlled because of the insulin resistance. So non-obese patients need a stronger metabolic procedure like the ileal transposition, which can increase the GLP-1. GLP-1 can be increased by exercise, by certain drugs, but surgery is the most effective method of increasing. Another word of caution in diabetics, in non-obese patients and otherwise, so the damage, the microatherosclerosis starts much before the patient actually starts showing signs of diabetes. In order to get maximum benefit from surgery, it is suggested that we treat them early. We don't wait for these complications to start or appear. This is the topic which is I would like to emphasize and brief you is the insurance in bariatrics. World over, we see that bariatric patients are covered by insurance in Europe, in Australia, in US, because primarily because the authorities and the insurance companies have realized that if we don't support these patients at this point, they are going to come back with a lot of complications. They can come back with knee replacement, they can come back with heart issues, they can come back with kidney damage, with retinopathy, eye damage. So a lot of these patients require a lot of medical help in future if this problem is not controlled or nipped on time. Otherwise, the financial impact on medical pharma sources is much, much higher. In India, we have been dealing with the IRDA and the different authorities. We've been trying to collect data and give it to them and trying to explain the fact that bariatrics actually takes care of all these diseases. And by spending a small amount right now, we can save a lot of expenses for these patients in future. Some companies, Indian companies, are honoring insurance in bariatrics like the Star Health, the New India Premium Policy, Bajaj Allianz. So these are the ones who are honoring these cases, and some of our patients are benefiting out of it. I urge the other companies to look into this seriously and consider bariatric as a part of their coverage, because this is something which is very important for future. I would like to share some of my case studies. A lady of 135 kilos after surgery, she's 68 kgs. Another patient who's heavily diabetic, who was on 126 kgs, 340 units of blood sugar of insulin on antihypertensives. 8 months after surgery, he has lost about 45 kilos. His blood sugar levels are normal. He's not taking any medication for diabetes or blood pressure. This is one of my most difficult cases. He was a diabetic for 30 years on 230 units of insulin. 6 months after ileal transposition, this patient lost about 30 kilos of weight, and he's at 70 kgs, which is his ideal body weight, and his HbA levels is 6.8, and he's only on one oral tablet for sugar, which is one of the most wonderful cases I have operated. He was one of the heaviest in Maharashtra. He's 245 kilos. He's lost 125 kilos after a gastric bypass. One of my youngest patients, he was just 12 years old and weighing 148 kilos. We operated a sleeve gastrectomy on him. He lost a good 55 kgs. He's below 100 and he's doing very well in school now. One of my African patients, he was 195 kgs. If you look at him, his waist was 100 inches and he's lost 102 kilos and he's looking wonderful and doing wonderful. Another heavily diabetic patient whose blood sugar levels of 490, 270 units of insulin, antihypertensives, ischemic heart disease. 2 years after surgery, he's lost 50 kilos. Sugar levels are perfectly normal. This young man, he's lost 110 kilos. He was my most obedient and wonderful patient. So there are many of them you can see. This lady has lost 70 kilos, and you see the difference, transformation. She's turned into a beautiful young lady and happy and as ever can be. Another medical student from Malaysia who's lost 110 kilos, and you see he's a different man altogether. So I'll be happy to answer some questions if there are from the audience.
Yes, we have already received a couple of questions. So the first question, as you know, as expected, what is the cost involved in this?
So the cost of the surgery varies from a different hospital to hospital that we do. Well, in short, it starts at about 2.5 lakhs and goes up depending on which hospital and what category of room you take.
All right. So the next question is again somewhat related to cost. In a populated yet price-sensitive country like ours, how will robotics shape up in the future?
So, as I said, robotics, because it is all patent product uh, controlled nowadays, till now, bariatric surgery does add to about 1.5 lakh of extra cost to the surgery because of the use of instruments, the drapes, and the use of the robo. But in future, because the patent is now getting coming to an end, and a lot of companies are coming up with more affordable robos. This surgery is going to be more and more cost effective in future.
Okay. So the next question is it is regarding the Egyptian woman Iman Ahmad.
Yeah.
I mean, what went wrong with the lady? Who is the fattest woman in the world? She would be coming to Mumbai for her obesity issue, right? So, what was her case? The participant just wants to understand.
So, see, as I said, most of these patients do suffer from multiple morbidities. They have multiple organ problems, and it is difficult to treat each one of them unless they lose weight. And the more they remain obese, the more damage these organs have already taken place. You will, so sorry to say, but you will never find a 200 kilo 70-year-old person. You'll never see them. They don't live that long. So most of these patients do have a problem, living a healthy life, and they are prone for complications. Of course, she was brought to India, and one of the most efficient surgeons, a good friend of mine, had performed a wonderful surgery. She did well, but probably the organs had already undergone so much damage that it was difficult for her to cope up. That's all I can say.
Yes. So, next question: is there any special diet patient needs to follow post surgery?
Absolutely. So, coming back to diet, as I said, that these patients have to understand one thing, that nature has not given them a metabolism. We are trying to achieve and get this metabolism for them somehow or the other by reducing the size of the stomach, giving them 5 or 6 small meals a day, including more proteins in their diet, getting rid of high calorie stuff like oil, sugar. So this is a general do's and don'ts which every obese patient has to follow. I follow it myself because I want to remain healthy, and I advise all my patients to diet and exercise regularly. In diet and exercise, there is no off switch, it is only on and on. You have to do it every day, and that's the way things go.
So we go to the next question. It says, do you think insurance coverage policies will change for bariatric?
Yes, insurance coverage is already changing. 5 years back, we didn't have insurance. Of late, we are finding a lot of companies are supporting bariatrics, and this will change because obesity has become almost like an epidemic. We are seeing more and more cases. 20 years back, when I started, we used to do one case a month. Now we do almost 10 in a week. So this is how common the problem has become, and insurance will be a way of treating these patients because it will save a lot of complications for these patients in future.
Okay. So the next question is, what is the infection rate with the spine related to the surgery? Is there anything like that?
Infection rate.
Yeah.
I mean, I don't know if I've got the question right, but this surgery is comparable to any other surgery. As I said, it's like a gallbladder or hernia surgery. We take care of the regular infection by giving antibiotics. and these patients go home the next day. Surgical time is about an hour. Hospital stays only 1 day, and there are three or four tiny keyhole incisions, so there are no stitches. And these patients behave like any other laparoscopic patient operated, and they go home the next day.
Okay, so we continue with the next question is what do you think about the government policies regarding insurance recovered in weight loss surgery? So the government policies coming in.
Government policy, as in, do I take it as an insurance coming in, or is it something else? Government policies, see, government CGHS has now recognized bariatrics. So, a lot of hospitals which support CGHS, the central government health scheme, they are supporting bariatrics. And the hospital where I work at, we get patients from CGHS. So, government is also recognizing this as a problem, and we have done a few. Bureaucrats and police personnel and other people in on duty in services under the CGHS scheme.
We move on to the next question is robotic bariatric surgery only recommended for morbidly obese individuals who have BMI of more than 32, or can it be offered to all obese individuals? Does it have a
Bariat-
better outcome over laparoscopic approach?
Robotic can be offered to all morbidly obese people. BMI 32 is the cutout BMI for bariatrics in short. Below BMI 32, we don't usually recommend bariatrics unless the patient has some complications and the patient really needs it. But robotic can be done in any weight individual. It is just a medium of operating. Has got nothing to do with the BMI.
Okay, the second part of this question is does it have a better outcome over laparoscopic approach?
So, a person who's very well trained and who is a good laparoscopic surgeon, frankly, they will not have much of a difference whether we do it laparoscopically or whether we do it robotically. But yes, robot does have a slight advantage in precision, in the tremors, and but studies world over have not shown much of a difference in the results. But in long surgeries, something like a prostate cancer or something like the ileal cases where it takes 5 or 6 hours, it is a tool which helps the surgeon to maintain his efficiency even after 5 hours of surgery.
So we see a lot of questions coming in. Again, is there a minimum or maximum age limit for bariatric surgery?
Yes. Uh, See, bariatric is technically and defined as between the age of 18 to 65. Anything below 18, we need to assess the patient properly whether they have completed their growth, bone growth, and only then can we take up these patients. And above the age of 65, we have to exercise very good caution and investigate the patient properly as to whether the patient is fit for surgery, and only then we take up. Otherwise, the safe range is between 18 to 65, according to the guidelines.
Yes. Next question. Does bariatric surgery have any impact on lipid profile?
Yes, absolutely. Lipid profile comes to normal.
Yes. Next question. There are people with high body fat percentage with a normal BMI. These are known as skinny fat people. Do you offer surgery options to such people since they are at a risk of metabolic disorders?
Unless they have multiple comorbidities like diabetes or uncontrolled blood pressure, individuals below 32 BMI are generally not offered bariatrics, even if they have a higher body fat percentage.
So we would take a couple of questions more. This means how do you decide which technique to offer? Sleeve gastronomy, gas
I got the question.
gastronomy or
So
RYGB
there are
or lab band. Yeah.
Yeah, so there are, in all, I've just mentioned a few, but if you go to really count them, there are more than 15 to 20 procedures now available in the umbrella of bariatrics. We have to do a thorough assessment of the patient, take their complete history, whether they are small eaters, big eaters, whether they are sugar or sweet eaters, whether they are regular eaters, whether they're going to exercise, not exercise, whether they have high cholesterol. So there are a lot of things which come into play, and then we form an algorithm, and putting everything together, the surgeon and the patient together decides which of the procedures they can undergo. So surgeon can help you choose the procedure, but at the end it is the patient who has the ultimate choice whether what they exactly want.
So, is there widespread awareness about bariatric surgery in India, especially?
Yes, India, as I said, in last 4 years, into the year 2014, we were clocking about 10,000 cases. Now we are clocking more than 20,000 cases in 3 years. So bariatrics is almost doubling up every 2 years, the number of cases.
So next question is, since India is the diabetes capital of the world and we do not have a solution currently, will bariatric surgery for 32 BMI, 32 plus BMI diabetics help control that?
Absolutely. So, in fact, now we have special approval, and there are cases where we can operate even below 32 BMI, uncontrolled diabetics. There's a wonderful procedure called the ileal transposition, wherein we manipulate the intestine in such a way that the GLP-1 goes up. The patient need not necessarily lose weight if they don't have to, so we don't staple the stomach as much, and we can just get rid of the ghrelin. We can get up the GLP-1, and these patients can lose about 5 or 6 kilos if they want to, but the diabetes completely comes under remission. Almost 90 to 94% of these patients will stop insulin on all tablets they are taking for diabetes.
All right. So we're taking the last question, and the person wants to know what is the follow-up schedule after the surgery?
So follow-up schedule, uh, in these patients, they have a regular follow-up schedule. In the first 6 months, they almost follow up 3 or 4 times with us. Then we recommend every 6 monthly follow-up. And after 3 years, we recommend at least once a year follow-up for these patients for lifelong.
So thank you, Dr. Abhay. We would proceed to wrap up this session. Thank you, Dr. Abhay Agrawal, for presenting on the topic, Is Robotics the Future for Bariatric Surgery? If you have any other questions, please send them at editor@ethealthworld.com. It was an engaging and insightful talk, and hope all the present participants have enjoyed the session. The recording of this webinar will be made available on ethealthworld.com. Thank you everyone for joining us. Goodbye.
Goodbye.